Now, starting the recording and starting the meeting. So everybody, stay muted until the Q&A so that we're not hearing a lot of other conversations. So anyway, welcome. Thank you everybody for being here. This is a topic that I think means a lot to a lot of people. And here we're featuring our own activists talking about what it is like to experience guaranteed health care someplace where it actually does exist. I want to thank Ting for doing is everybody muted for the moment? Okay, thank you. So Ting, thank you for handling the Zoom and hosting it with NIPAN Zoom. This is Uptown Progressive Action, as most of you know, is a chapter of NIPAN, New York Progressive Action Network. We appreciate that the Zoom is compliments of NIPAN and the Ting is handling it. And Tim Frasca, who is our policy person, research chair. We've had a few similar titles for you. Research director, I think is your title. Anyway, so Tim is going to be handling the Q&A and the stack and the chat. So the way that we're going to do this is have each of the speakers speak all in a row, and then we'll have plenty of time for discussion and Q&A at the end, and you can direct it to whichever speaker you want or just generally make some comments. If we don't know you or you're not on our email list and want to be, just put your name and your email address in the chat. So I think we can begin. This is really a pleasure to have all of you speaking about your experiences that are different from what we have in the US. In the US, it seems so normal to be paying for healthcare, but in other places, it is not so normal, and other places are rather outraged and shocked sometimes when they hear about what our so-called healthcare is like and our profit-making system. So, we sometimes barely even realize that there are other ways to do things, but, in reality, we're not paying the fire department to come. The fire department doesn't have to be a network. We're not going to the library and being charged for borrowing a book. We're not charged to send our kids to public school. It's just part of the public good. And that's what we're going to be hearing about, so that our vision is one of a society of conscience. And in many places, you're going to hear about how that works. Not always perfect, but when it's not always perfect, sometimes has more to do with underfunding than that the principles aren't the principles that we could actually put into effect here and that make sense for guaranteed health care. One thing we have that nobody else has is medical debt, medical bankruptcy, and possible not to have that in our lives. What comes to my mind is there was a story, I don't know if it was a Facebook post, I don't know who it was, but I remember somebody saying that they were working in another country, and this was a woman who developed a lump in her breast and she needed to be seen medically by someone. And her coworker said, "You can be seen by somebody today. There's a clinic right down the street. Why don't you go?" And she said, "Well, I guess I have to call first." And she said, "Actually, you really don't even have to call." But she said, "I'm going to call anyway." So she was on the phone with somebody at this clinic, whichever country it was, and I'm sorry, I don't remember. And she was making arrangements to be able to come in to have her breasts checked. And then she said, "And please, what is the copay?" And the person on the other end of the phone said, "What is a copay?" So this is what we contend with, and it's totally unheard of in some of the places that we're going to be hearing about tonight. So, once again, it's really great not only to be hearing from people about this, but it's, our activists that we work with all the time who are going to be presenting tonight. So I think we're going to start with our sister brother team. We've heard from them before from the UK, and that's Zara and Ali Ashgar Abidi. And whoever wants to start first, we've heard some real stories from both of you.
I will defer. Thank you, Julie. It's a pleasure to be with you. Thanks for the invitation, and more broadly, thank you to Julie in particular and everybody on the call for all your efforts in this fight. I feel like we're getting closer, and with the efforts that we're kind of going through today, we'll take that one step closer to getting to universal coverage for everybody in New York. Because having lived in a system that has universal coverage, I can tell you it's a very beautiful thing, because it immediately reduces your anxiety, right? You know, Julia, earlier you said something about what is copay. I want to build on that. In other parts of the world, you say, what is medical debt? No, that's a completely alien term, because 100% of the people are covered 100% of the time, and that offers a lot of freedom, right? So freedom of employment. You don't have to think, oh, if I want to get this job in another enterprise, what is that going to do for my healthcare? You don't have to think about, do I get coverage on day one? Can I afford COBRA for the intervening 2 weeks, say, while I transition between firms? Other types of freedom to choose your own doctor. Right? We hear a lot of it. This, you know, if you like your insurance, you can keep your insurance. Does anyone like their insurance? Does anyone understand their insurance? I would say no. And then even if you do, you know that some things are in network, some things are out of network. So, for example, where I live in Battery Park, there's a dental office right on the ground floor here, which is amazing. And I was going to go there this week until I realized it's out of network. So this convenience of having a dentist on the ground floor is completely wiped out because it's out of network. Whereas in a universal coverage system, 100% of medical practitioners, whatever the specialty, are in network. And I think another benefit of universal coverage is when you take the profit motive out, it really allows you to build trust between you and your physician, because you know they're not motivated by any financial gain for themselves, right? If that's prescribing medication or recommending a procedure or otherwise, they are much more likely to impart advice and make recommendations based on what is in the patient's interest. Other benefits of living in a universal system is, you know, prescription drugs. They're the highest in the universe here. Whereas in a universal healthcare system, because the government has buying power, they can negotiate much lower prices. And so if Pfizer or Eli Lilly want to sell into Britain, they deal with the UK government, or they have no sales. Those are the two options. And because of buyer power, you see, you know, a lot lower costs. So my son turned 2 a few weeks ago, early January. His birth cost $18,000, and that was a normal delivery, no extra nights in the hospital, nothing like that. It cost 18 grand. Now, luckily, I paid 2 grand, which, you know, I'm not thrilled about, but it's not the end of the universe. But that's despite paying, you know, about $700 a month in healthcare, in health insurance through my employer. And when you look at the cost, you know, we talk about, you know, can we afford? Yeah, heck yeah, we can afford it. And the reason I know that is when I lived in London, my net take-home pay was ballpark 60% after, you know, deducting benefits and tax and everything. In the US, in living in New York, it's about the same. But that coverage in the UK gave me complete healthcare coverage, no copays, no deductible, nothing. So I really do think it is possible. What else do you want to cover? Yeah, so that's what I wanted to cover. Ultimately, I know universal coverage has its own flaws, but I've lived in both systems. I know the benefits, the pros and cons of both. And I would say that if I had to choose, despite the flaws of universal coverage, I would choose that 7 days a week.
Thank you. So would I.
Yeah, so I will add on to my brother's experience here. I moved to this country when I was 23. So for the first 23 years of my life, I lived in a place that had universal coverage. And in the same way that people who have only lived here don't even comprehend that there's like a difference somewhere else, I also hadn't comprehended that what my experience was unique, or that I would ever live somewhere where I would have to think about healthcare. You know, my 23 years there, if I needed an appointment at the doctor, I would make an appointment. You know, you don't need to register when you go in to like sign up with your insurance. You don't need to even think about, there's no cost associated, so you just don't think about it, you just normal to me. And I think one of the benefits of that system is that your health decisions are purely based on your health and your health needs, rather than on things like, can I afford it? Is the provider in network? And when I came to this country, actually, I studied public health. And one of the things that you soon understand with the way the health system works here with insurance is that one of the important things that is given weight to is like that patients have skin in the game. So the concept that a patient is thinking about the cost, not just the insurance company. The patient is also thinking about cost when they make a decision about, should I go see a doctor? And I don't believe that that's something that they should think about. And I don't believe that people make those decisions, take those decisions lightly. Like, no one goes to the doctor for fun, right? Like, you only go if you really need to go. And so this idea that, like, you know, you should deter people because they have to think about the cost, to me is just, and it's built into the health insurance system. It just doesn't make sense. Yeah, and then when I came here, I've been a student, I've been someone who's had a part-time job, I've been someone who's been between jobs, I've had, you know, good coverage through an employer, and so that whole process has changed the health coverage I've had. So like there's been times where I've been between jobs and I'm like, oh, I need to be really careful that I don't get sick because I, you know, need to wait till my new insurance kicks in. Or I will, for example, like where I work now, I have the same plan as I did as my old, at my old job, but it's still like different coverage somehow. Like in essence, it's the same plan, the same insurer, but I couldn't like see the same providers. So there's all these little things that like you don't even like realize are going to be an issue. And if I compare it to my experience in the UK, it's like, as my brother said, it's like literally whichever provider you want to go to, you go to. There's no, as long as they are taking new patients, let's say, you can go to them, and there's no other barriers to that. So yeah, I mean, I think I was blessed to have that experience, and I almost took it for granted when I had it. And coming here, I have now I've experienced this, I really do understand like what a beautiful system it is, and it's something that I really do think is possible. The way New York's heading now, and especially with COVID, it's really put into perspective how important universal healthcare is. I work in the healthcare system now. I work for a hospital, and seeing the way we responded to COVID, there's on the side of providers and clinical staff, there's such a want to have health equity and to be providing care for the people that need it most. But you're still so restricted by things like insurance, by things like, for us, for example, like all the health equity work we do is donor funded. And that's fantastic that we have donors that will help us prioritize health equity, but it shouldn't be the case. We should have a government system that allows us to do that anyways. So I'm happy to take questions, but yeah, 100% second my brother's experience that universal healthcare is absolutely possible. And I think it's especially possible in New York. And I do feel like compared to when I first joined these meetings a few years back, it does seem like we're edging in the right direction. So it's definitely encouraging.
Well, thank you both for helping us edge in the right direction. I think the more we hear stories like yours, the more people in this country realize what we're not getting that is a basic human right. And particularly during COVID, we're seeing those, health disparities that are shocking and tragic. And thank you both for being voices for something that can be. So the next person we're going to hear from is Tina, who is one of our UPA people we've known for years and is from Denmark and is going to talk to us about healthcare in Denmark.
Hi, I'm Tina, and this is what every person, can you see it? Every person in Denmark has one of these. If you're, if you're undocumented, you don't, but there are very few undocumented people in Denmark. But when I grew up in Denmark and spent the first 29 years of my life there, and it never occurred to me to worry about healthcare. I was into a lot of alternative stuff, so that was not covered, obviously, but that was my main concern about coverage. It's how you pay for, I am sorry, my dog is interfering. Then when I came to this country, I learned, progressively, what it means to have healthcare, to not have healthcare, how much time you spend on figuring out insurance, who you can go to. Your insurance doesn't pay, you have to get involved, and it's eons of hours and hours that you spend dealing with the relationship between insurance provider and yourself. I can only second what the two previous guests said. Clearly, given the choice, I will choose the Danish system any day, okay? I looked into the history without going into too much detail. So we seem to have a several hundred-year-old tradition in Denmark for the public public governance being involved in healthcare. Annie, shut up. Sorry. Actually, as late as 73, it became a system without any kind of insurance. And I wasn't even really aware of it because I never thought of it. I asked my mom, she said, really? So there was a kind of a private insurance that was in effect since 1890 something. And anyway, so it was probably most people's union. It was part of your union arrangement that they paid a fraction into a private health insurance. But really the public, what we say in the state, which is the national government in Denmark, subsidized the vast majority of expenses. Okay, so now since 73, we've had the neoliberal development as any other country has on earth, basically. And of course, we want to do what the Americans do. So because when you cut expenses, when you cut, the public health system, you get longer waits and so forth. And they have more patients to see per day. And so the quality of the healthcare is not always as good as it should be. And what happens is that then private insurance came back in the picture. So now we are a very small country, like 5.7 million, about 2+ million are covered under some kind of private healthcare, which enables them to bypass wait lists and go to a private clinic or a private hospital. But the interesting thing is that the doctors who work in these private clinics are paid by the state, and they're paid higher wages than the people who work in the public system. So without getting too complicated, it's both a how can I say, it's a model for how to do things, Denmark, and it's also a model for what happens when you stop funding things appropriately. And so I think that's something to keep in mind as we're doing this here. Again, like there are certain things that you have co-pays for in Denmark, such as chiropractor, psychologist, dental. If you're over 18, under 18, it's fully paid. but over 18, you have some forms of copay, but again, and some form of copay for medication. But depending on how much you use, you can reach a subsidy level of 100%. So people who are high users of certain expensive medications end up not paying for it at all. So it's kind of, there's a means test involved in this as well. I went back to Denmark for a year, 2 years ago, and all of a sudden and the first thing I received in the mail was this, and it was a huge relief. I had 3 years of not being insured here. I worked for someone who didn't pay insurance, and that was before Obamacare, and it was impossible to get insurance. And I literally every day thought, you know, I was aware that if you get some kind of horrible disease, such as cancer or something, that there is help to be had here. But what if you break a leg, or you have something somewhat wrong with you that requires a hospital visit, but it's not life-threatening, so you are literally stuck. I used to say that my healthcare was Denmark. So because I kept an address there so that I, at any time, particularly through those years when I didn't have insurance, I could head back if something happened. So since I came here, it's been at the back of my mind constantly. And that was something I didn't experience the first 20 years of my life, 29 years. And for the year that I was in Denmark, didn't experience it again. All my relatives who had serious illnesses have, you just get taken care of from beginning to end. Everything is paid for. There's improvement to be made, but it's in the area of quality and prevention and, you know, just more funding. So yes, it's a model and a lesson to be learned from what happens when you don't fund. So I think that's what I'll say for now.
Thank you very much, Tina.
Yeah.
All right, so our neighbor to the north, Canada, we're going to hear from, again, one of our very active members, Rana Sufi.
Hi, everybody. I actually prepared something. I wrote it down, so I'm going to be reading it to you. I was born and raised in Ottawa, Ontario, and I have also lived in Montreal, Quebec, for grad school. As a Canadian residing in Ontario, I was covered under OHIP, which stands for Ontario Health Insurance Plan. Whenever I had to visit the doctor, I simply had to show my card and receive care at any hospital, lab, clinic, or even GP at a family practice. Ultimately, we have a federally mandated, provincially administered single-payer healthcare system. Yet, this doesn't mean that Canadian residents face restrictions based on where they live. As someone who lived in Ontario and Quebec, I experienced interprovincial coordination, especially when it comes to the hospital system. I moved to New York City in 2015. I was 26, turning 27. And it took a couple of years before I enrolled in insurance, let alone try to even use it. I was resisting. I was attached to my health card, which granted me access to doctors across Canada. I didn't want to let go of that privilege, which was a basic provision just a short time ago. It was such a nice feeling to simply have to show my card to be seen. Now I have to do research to find in-network providers in Manhattan for a plan based in New Jersey because my husband's employer is housed there. Not to mention that those willing to accept pithy reimbursements are more likely to be larger corporations, which speaks to the economic dimensions of this as well on a larger scale. I've been blessed with few medical issues so far in my life. However, knowing I could see my family doctor or gynecologist when I needed it was a huge comfort to me. Also, I had privacy. after turning 18, unlike young people here who, because they're under their parents' plan for very good financial reasons, don't. Since dental health isn't covered in Canada, unfortunately, and neither is vision, except for some exceptions, which I'm not even that clear about, but I know there are a few exceptions. I was under my dad's work plan until I was 25. So he knew all about my teeth and my eyes. And by the way, my impression is that the private insurance plans, at least from 9 years ago when I was still there, were less expensive and more generous than the equivalent here. I don't have any stats on that. It's just my impression from my experience here and there. Some people believe that, and this is something I think, Zira, you mentioned, that universal healthcare means overuse of services. And I don't think this is true. My family would go for yearly checkups or as needed. Folks generally don't enjoy going to the doctor. There are people who exhibit hypochondria, but these symptoms are not caused by universal healthcare. Trust me, after all, I'm a psychotherapist. In Canada, we are free to choose when and where to go. Here, we are constrained by financial means. Networks limit those with insufficient funds to transcend them. And the bureaucratic entanglements we all must experience to have our basic health needs met create unnecessary obstacles, which I did not face before moving to the United States. What my experience in Canada has taught me is that if properly designed, a state-based single-payer healthcare system is the way forward. The criticisms wielded against it are projections of what's inherently flawed and costly about private health insurance: more bureaucracy, less freedom, and the elimination of small practices. Thank you.
Thank you. All right, so I think I'm learning more every time I hear all of you speak about your experiences outside of the United States. So I think many of us are very curious about Cuba because we don't get a lot of good news intentionally about Cuba in the United States. So very happy to introduce Dr. Mary Louise Patterson, who is also one of our very active members, to speak to us about healthcare in Cuba.
Good evening, everyone, and thank you, UPA, for organizing this, and to all the prior speakers who spoke about their, shared their personal experiences. I'm actually not going to do that, and I am going to read like Rana did, but I really am going to talk about the healthcare system in Cuba in terms of its structure, and to try to give people a sense of actually how it works. So in December 1959, a small island nation, primarily rural and poor and illiterate, only 90 miles off US shores, rocked and awed the world with its overthrow of its corrupt, inefficient government and replacing it with a band of mostly bearded, yes, there were a few women among them, young, fierce revolutionaries in olive green fatigues and Doc Marten-like boots. They were headed by a man belovedly known as Fidel. Over the next year and a half, 2,000 of its 3,000 doctors abandoned the country for wealthier climes. Still, in 1961, the revolutionary government was able to establish a national health care system and phased out what was left of the private one, declaring that health of the Cuban citizenry was one of the highest priorities. And then in 1967, access to healthcare was codified as a human right in Article 50 of the new Constitution, charging the Ministry of Public Health with a mission and responsibility to provide healthcare services to all its citizenry with an emphasis on prevention. Today, 60 years later, All healthcare on the island is financially planned and organized by the government. It's of the highest quality possible, with statistics rivaling developed nations like ours, and it's provided free of charge. That achievement has been hard won, and in the face of protracted attempts by the US government to smash it, including an illegal economic blockade that has limited Cuba's access to pharmaceuticals, medical technology, and other material resources. But this turned out to have an unexpected effect, not only on Cuba, but on Cuba's relationship to the world, as it forced Cuba to focus on medical education and the production of doctors. Cuba went from only 2 medical schools in 1959 to a medical school in every single province today, totaling 21 for a population of 11.3 million people. The US, for instance, has 154 medical schools for a population of 331 million people. Cuba's current health challenges besides COVID are contending with old, defraying, outdated medical buildings, lack of access to beds, bedding, bandages, and other medical basics. It's also managing an aging population that has increasing healthcare needs, but is no longer productive, no longer contributing to the GDP, the gross domestic product. It's also dealing with chronic diseases of the West, cancer, heart disease, diabetes, hypertension, asthma, and dementia, which represent a long-term drain on their medical resources, plus the dangers from negative climate changes. Cuba has a 3-tiered healthcare structure: primary, secondary, and tertiary, which is differentiated to meet the needs of each province, community, population group, family, and individuals to guarantee equity and efficiency based on an assessment of the health situation at each level and on each area's particularities. The primary level is the biggest responsibility, as it's the basic one, providing and monitoring the health of all the communities in the entire nation. The primary entry is a decentralized point of care called the consultorio, which handles 80% of all medical visits. The consultorio consists of a doctor, a nurse, and often an outreach person. They all live in that neighborhood. The catchment areas are usually around 600 people, more or less. The doctor often lives upstairs over the consultorio. They have a list of and know everyone in their catchment area. They keep track of every illness, every medical need, as well as public health conditions, and report all of those to a central registry. They do home visits, guarantee vaccinations, give prenatal care, etc. They are connected to a regional polyclinic. The second tier consists of provincial managed hospitals and centers of specialization and rehabilitation. Patients can go directly to these facilities, and in cities like Havana, they often do. But the system is designed for the entry point to be at the primary level with referrals up the chain. This level handles approximately 15% of all medical visits. And then there's the third tier. This is the nationally administered specialized hospitals and centers that handle about 5% of medical visits. They also tend to handle a lot of international visits. In a city like Havana, people often go directly to one of the specialized hospitals for care, bypassing the primary and the secondary tiers. For instance, there's an urgent care at the Eye Institute/hospital in Havana that sees walk-ins. I've used it myself. The Ministry of Public Health, MINSAP, is responsible for epidemiological control, for instance, fumigation and sanitation, care of the elderly and the disabled. It also oversees the medical schools and state productions of vaccines and domestic and imported pharmaceuticals. It oversees and sets all the policies, priorities, and practices of prevention and public health. The previously mentioned US blockade has definitely hampered Cuba's growth, but it's also forced Cuba, like I said, to develop an innovative domestic biopharmaceutical and biotechnical sector. Cuba now exports pharmaceuticals such as the meningococcal B vaccine to Europe, and it has developed a monoclonal antibody treatment for several different cancers and a world-class rehab program that many foreigners can and do take advantage of, including Americans. I don't know if any of you saw a documentary on Cuba about a year ago, which highlighted an American who would go to Cuba every year for his cancer care. Where was I? All of this was Fidel's pet project. He became as knowledgeable as many of the doctors and scientists and often gave speeches at international as well as local medical conferences held in Cuba. I've heard him talk about MRIs as if he was a medical engineer. Overall, Cuba emphasizes the holistic nature of health, well-being, and dis-ease to the patient. So the patient is approached as a biopsychosocial being upon whom biological, psychological, community-based, and social forces all intersect to determine the patient's health status and ability to get and stay well. Outcomes. There's an accepted given in looking at the general health of a nation, and that is the association between health and income. So it's well known that persons with higher incomes have better general health and health outcomes. The GDP is a measure of national income across nations, or it can be. The per capita GDP for Cuba is $5,700. For Canada, it's $46,000. And for the United States, it's $46.3 thousand. But Cuba spends around 10% of its GDP on public health, while the United States spends only 7%. And Cuba gives priority to infant and maternal health. Let's look specifically at the incredible enormity of what Cuba's accomplished since 1961 by looking at infant mortality, maternal mortality, and life expectancy. Infant mortality. In 2016, Cuba's overall infant mortality rate was 4.2. Prior to the revolution, it was close to 100 per 1,000 live births, compared to 5.7 for the United States. So Cuba's 4.2 now. The United States overall is 5.7, but if you're African-American and you happen to be an African-American newborn, it's 10.2, while for white newborns, it's only 4.6. And in Latin America, it's a horrific 14.8 per 1,000 live births, but only 3.4 in the European Union. Maternal mortality. Cuba's maternal mortality has gone down from 53 per 100,000 live births in 2008 to 36, in 2017, compared to the United States at 17.4. But if you're African-American, it's 37.3, while for white women in the United States, it's only 14.9. And we all recall how Serena Williams almost died after delivering her baby. Life expectancy. In Cuba, it's 80 years. In Latin America, it's 75. In the European Union, it's 80.6. And the United States, it's 78.6 overall. But for whites, it's 78.6. And if you're African-American, it's 75. And it's also regionally determined in the United States. In 2014, WHO reported Cuba had 7.5 doctors per citizen, the highest in the world. In 2015, WHO certified Cuba's eradication of maternal fetal transmission of HIV and syphilis. Beyond all that, the Cuban government has shown the world an exemplary solidarity and humanity. Since 1960, Cuba has sent over 130,000 medical professionals on aid missions to developing nations, primarily to the global South. But we may remember, or you may remember, that it also sent physicians to developed nations like Italy this past spring to help them confront their COVID crisis. In 2004, Cuban launched Operation Miracle in collaboration with Venezuela, sending doctors all over Latin America, providing free eye surgeries to thousands of the underserved. In 2005, after Hurricane Katrina devastated New Orleans, especially African-American citizens and their neighborhoods, Fidel offered Bush medical personnel and supplies, but Bush snubbed the offer. It was during that period that Cuba developed the Henry Reeve Brigade. Since its start, that brigade has sent over 7,000 experts to 21 countries, seeing over 3.5 million people in response to hurricanes, earthquakes like in Haiti, and epidemics like Ebola in Africa. The brigade has been nominated for a Nobel Peace Prize this year. Cuba also provides healthcare specialists to many underdeveloped countries on a long-term basis, for which it has earned billions of dollars. In 2014, they reported receiving $5 billion in US dollars. You may also recall the US government's role in sabotaging Cuba's medical presence in Brazil, for instance, by encouraging the Bolsonaro government to eject all the Cuban doctors who had been working there, leaving many remote areas of Brazil without any medical care at all. And lastly, a program that Fidel started in 1999, which is close to my heart, is the Latin American School of Medicine in Havana, known as ILAM. It is the largest medical school in the world. I repeat, it is the largest medical school in the world on the little island of Cuba with 11 million people. It's dedicated to training doctors at no cost to them from underserved communities in Latin America, but now expanded to include Africa and Asia and Americans from underserved marginalized communities here. The only ask on Cuba's part was that they agree to return to those very communities and provide medical care. Fidel told Reverend Lucius Walker, the head of IFCO, back in 1999, that ILAM would train young African Americans if Reverend Walker could create a way of identifying, vetting, and preparing those young people for that opportunity. We on the Medical Advisory Committee of IFCO, and there's one person on this, there's another person on this webinar tonight, or this Zoom tonight, who's a member of that very committee. So
I'm here.
Hi, Max. So we on the Medical Advisory Committee of IFCO now extend that opportunity to young people from other underserved communities in the United States as well. So not exclusively African American, although it started that way. Since the first graduation class of 2005, ILAM has graduated over 20,000 doctors, including almost 200 from the United States, most of whom are fulfilling their promise. So I'll end there and entertain questions. And I'm glad Maxine is on because she can help. She actually went to medical school in Cuba and lived in Cuba for many years. And so she can help field some of those questions around Cuba and Cuba healthcare as well. Thank you very much for this opportunity.
Thank you so much, Mary Louise. And thank you to all of our speakers. So we're going to open it up for questions, maybe some dialogue among the speakers. And if there's anybody else in your questions and comments who wants to say something about somewhere that you have experienced guaranteed health care, we're open to that as well. So Tim Frasca is going to take Stack. You can write Stack in the chat is probably the easiest way. I don't know if anybody is on the phone here rather than where you have access to the chat, but you could also raise your hand or raise your little hand icon, or Tim, maybe tell us what's your favorite way of taking Stack.
Yeah, if you can, but I'll be watching all possible options. If you raise your electronic hand, if you ask this question in the chat, I'll call on you and we can proceed that way. There's already a question. If somebody's asking if Mary Louise could describe her experience, I guess someone wants to hear the personal side as well. Can you do that, Mary Louise?
Sorry, I'll try. I did not use much in terms of the healthcare in Cuba, but I have to say, first of all, Cubans are very proud of their healthcare. The next thing that you notice as an American, at least that I noticed, and I'm also a physician, is that Cubans are very knowledgeable about their bodies, about the body in general, how it functions, and their bodies specifically. They know the names of all of their medications, especially the The chemical names, a lot of the times I don't even remember the chemical name. You know, it's Elavil or it's Tylenol, you know, not acetaminophen. That personal relationship with their doctor, the fact that the doctor lives in their community, and they see the doctor not only in the office, but they see the doctor on the street and in the supermarket and, you know, at the daycare picking up the kids. And so there's a real personal relationship and investment on the part of the doctor in making sure that her community, and a lot of the doctors are women, her community is safe, is healthy, has the right sanitary conditions. And they're available for you to drop in. There are scheduled appointments, especially for healthcare maintenance, routine healthcare maintenance for children, your annual physical, or if you're diabetic. The other thing is that doctors also make house visits. So, you know, although here that's the carriage trade, if you get a house visit from a doctor, and you're going to pay through the nose if you get it, if you can get it, if your doctor does do it. There, those who are housebound, who are bedridden, get visits from both the doctor as well as the nurse. And this is done periodically. So it's a very hands-on, as you can imagine, because they don't have the technology. They're not doing Zoom healthcare visits in Cuba. And yet it's an island that has 10 million, 11 million people, the size of New York City, and only had 140 some odd deaths from COVID, with nowhere near what we have in terms of medical technology and all of the medical tchotchkes that we have. And yet they've been able to contain the spread of the virus, and we haven't. They're starting vaccination now. They've developed their own vaccines. They've started vaccinations. And this is done, they'll vaccinate the entire country. And we can't, I mean, the rollout here, the whole management of COVID here has really been criminal. And this past government has blood on its hands. There was no reason for the number of deaths that we've had. And this abysmal, chaotic rollout of the vaccine. And none of that would happen in Cuba at all. So I'll stop there. Maxine may want to add something, but I'll stop there.
No, I think you're doing fantastic. The only other thing I would add is that the nurse lives on top, also has an apartment in the first family doctor program. And also they were given a plot of land so that they could make their own natural medicine.
Are there any other questions that leap to mind? Okay, I see Connie raising her hand. Go ahead. You have to unmute yourself, Connie. Connie, unmute yourself first.
Unmute yourself, Connie. We can't hear you. Connie.
Okay.
There you go.
How do the Cubans pay for this comprehensive system? Taxes? I mean, I don't know. They have a lot.
Yeah, it's not taxation like we have here, but it's obviously taxes.
Okay.
It's paid for by the government, but it's obviously, you know, based on the
Ability to pay?
production. No, the Cuban people's production of you know, of goods that the government then sells. So it's government funded, but the government is funded by, you know, both by an indirect taxation. But also, as I mentioned, they get money, for instance, because they have a lot of doctors externally. They get a lot of money for that. you know, they have commerce with the rest of the world, excluding the United States. So there's money that's generated there as well.
Mhm. Okay, thank you.
There's a question in the chat. Could you tell us about the maternal care in Cuba? Do they have midwives?
They do have midwives. They also have maternal hospitals, which is something that the Soviet Union also has, and a number of other European countries had maternal hospitals, so that the childbirthing is done, and abortions, if they are medical or surgical, are done in these maternal centers or maternal hospitals, and they are throughout the entire the entire island. So you don't deliver in a general hospital, you deliver in a maternal hospital. I mean, unless there's some kind of emergency, and but ordinarily you deliver in a maternal hospital, but you're followed by your family doctor, your local family doctor, unless you're having some complication.
Further questions? While you're thinking about what you want to ask or comment, I will weigh in. Since we're talking about our personal experience with other systems, as some of you know, I lived in Chile for many years, and I was in the private system for a time and the public system for a time. And it's I'd like to just tell you an anecdote, because all of this information, I keep filtering it through what does it mean for us as advocates trying to win the propaganda war against very potent adversaries, obviously, and what is it that makes people resist this idea of a universal system that covers everyone. And I want to offer one insight. Chile's a very class stratified society, and the income distribution is extreme there. I think it's not as bad as Brazil, but in that direction. Something that is very rarely discussed when people talk about what a great economy that Chile has had historically in the last 20, 30 years, although not recently. I was involved with an AIDS project there for many years, and I would visit hospitals. And I remember one day going to see some people in a hospital in a fairly, let's say, lower middle class section of the city with large poor sections. And you couldn't freely roam around in the hospital as a visitor. There were certain hours and there were restrictions. I came to the doors, some side doors, and there were all these people outside who were not allowed to go in because it wasn't visiting hours. When I walked up to the door, they opened as if I had said some magic words. The doors opened and I was allowed in because they assumed that I was the doctor because of the way I look. Or that I must be important enough to be able to just not even be asked for ID. I mention that because I think one of the things, and it very rarely comes up in our discussions, but I think one of the elements of the resistance to a universal system is that a lot of people don't want to hang around with poor people in the waiting room. Yeah. They don't like the idea of a system that applies equally to everyone. Now, maybe I'm wrong. I'd be interested to hear other people's opinion. But I suspect that for many people, the idea that they have to pay more and get less is worth it because they still feel like they're being able to enjoy certain privileges and having nicer surroundings. Maybe getting in to see the doctor more quickly without having to sit in the waiting room. But, people enjoy the idea that they belong to a slightly more privileged class of society. So just throwing that out there. Thanks. Who else has a question? Oh, here's a question. No, that's the old one. No new. I don't see any.
in Cuba, they've tried to bridge that city-country divide. Tim, not quite the same that you're talking about, but trying to provide in the rural areas the quality of healthcare that one would get in Havana. And, you know, they've not succeeded completely. But in terms of, for instance, as I said, life expectancy, infant mortality, that really is nationwide. So that differentiation between classes or between city and country, although it exists, is nowhere near as stark as it is here and in other places. And that's also true for the Afro-Cuban population. They're receiving the same quality health care as the white Cubans.
Thank you. Julie, you have a question.
Yeah, I was just going to comment, that we see this so much in the United States. And when I went to medical school, which was a very long time ago, it was just so clear. There were the wards, one bed right after another in those days. This was in Buffalo, where people had no privacy, and then there were the private rooms, and the medical students and the interns and residents would all be taking care of the patients who were poor and on the wards and in the clinics, and and then there was the private part of the hospital. And I think, this is a bigger question than just healthcare, but I think that we're taught to look at things that way in this society. We're really not taught to have a view of everyone is, so to speak, family. It sounds from what Mary Louise is talking about, and I'm curious about the other countries where there's more equitable health care. If there's so much of that emphasis on class and how different we are, I think that, obviously the systems themselves, and we can talk about this and have this be, our life's work. But I think, in looking at how different countries respond to COVID, there's an element of that as well. The leadership, for example, in New Zealand, where there's this feeling that, we come together as people who care about each other in our communities as if we are one family, and she is listened to. And I think that that's very different from what we actually teach from day one in the United States, that there is this tremendous sense of we're different from each other based on money. We're different from each other based on race. So I'm interested to hear about that aspect of it. That's in, like Tina, how does that look in Denmark?
I'm going to unmute myself. So yes, so obviously Denmark has a reputation for being a rather egalitarian country, and to some extent that is true. It's also a very small country. It's smaller than Cuba. You said 11 million. We are 5.7, right? So it's tiny. It didn't used to be so tiny, but that's a while ago, and we lost a bunch of wars. So basically, where you see the real expanse of what you can say, what we call welfare, public welfare, is during the 60s and early 70s. So, and also I researched a little bit. 1933 was an important year. So it mirrors what happened in a lot of other countries. And I think as you see increasing inequality and resulting marginalization of communities. And now you see with the globalization and immigration, we have about, and now we have a rather sizable Muslim minority. As you see all these things increase, at the same time as the neoliberal cuts to public budgets, because there's nothing like promising a tax cut that to win an election, right? So it's been a competition to who can save on taxes more. And then as services decrease and inequality rise, there's that drive to special. I want special. So basically what the discussion is in Denmark with the private insurances, and they cost a fraction of what they cost here, okay? And everybody still has equal access to the public system. So it's basically younger, typically more male, typically more white, and employed who are covered by those insurance, which are frequently paid by employers because they don't want to wait, because their time is so valuable. So the people who do have to rely 100% on the public system are lower income, maybe not, able to work anymore, older people, minorities. So the connect between inequality and universal, high quality healthcare is totally there, as far as I see it, and including Denmark. Although I do want to stress, everybody has a right to healthcare in Denmark, so you cannot be denied. Okay. There's no such thing as denied. You might have to wait a little longer. You might have to share the room, but everybody has, a guaranteed right to good healthcare. I want to mention one more thing in terms of the COVID. Denmark did not fare as well as Cuba with the COVID, but one thing that is obvious to me when I speak to my family members, we have a national system, right? So if I go to my doctor in this city and I travel to that city at the other side of the country and I get sick, it's a system where you go in and there's transparency, and it's not like, which insurance do you have? Okay, I don't have your records, it's that. And that, in terms of COVID, is it's a huge asset. We have a national system. We can get in touch with everybody. It's not like here where my mom asks me, so how do you get vaccinated here? You basically have to take the initiative, right? You have to call up and say, I don't qualify personally right now under the current criterias, but there it's a nationally organized system. They decide who gets it first, and then they call you in and you get an appointment. So there's no one falls through, unless they want to fall through, right? Unless they absolutely don't want a vaccine, which I'm not ruling out that there are a small minority of people who might feel that way, but I really don't think it's a lot. Whereas here it's like first come, first serve, and if you don't have the wherewithal to figure things out, you can fall through the cracks, and you do fall through the cracks. So that's what I wanted to say.
Colette, speak up, unmute.
So I'd like to ask Tina, so in Denmark, so how is the public funded, and how does the private, who pays for the private and who pays for the public?
Right. So we have a national healthcare system. Family doctors, they want it's a private business in the sense, but you never pay any money. So if I go to the doctor and I have a headache, there's a fee where they say, the government pays that fee that the doctor then reports, For the private healthcare, there's a great overlap between the providers. So some will work in the public system. I mean, I'm sorry if I'm being incoherent, but hospitals you're all publicly run, and the doctors receive a set amount of money no matter what they do, right? According to where they are on this, on the hierarchy, and nurses and so forth. The private hospitals, there's a guarantee in Denmark, a treatment guarantee. If you have not been offered treatment for whatever condition you have within 30 days, the government pays for you to go to a private clinic. So they pay, if you want to go to a private clinic and you want to bypass the public system, you have to pay yourself. And that's where the private health insurances come in. But for instance, if there's a wait time and you have cancer and you're not seen in 30 days, even if you have like a meniscus tear or something, you are then fully funded to go to a private hospital. So it's not like here, and it's not a good thing if you ask me, because what it is, it creates like a two-tier system of healthcare. And actually, doctors make more in the private system. So and they have better work conditions because they basically are in charge, right? So there's an incentive for a lot of what is considered the really great providers or whatever to go into the private system. Some people go back and forth, but there's a high subsidy for even the private hospitals. So if you ask me, it's really stupid that we have this two-tier system. I think it is because if you cut services, at some point, the people who have more money are not going to wait. They're not going to sit around and wait for a doctor if they can bypass it. So I don't know if that answered your question. And I also wanted to say, obviously, education is free in Denmark. So if you're a medical doctor, you go to medical school, you're admitted based on your, we don't have exams, we don't have exams it's your average grades from when you finish your 12-year education. And based on that and certain other things, you get admitted and you don't pay. So there's no, you're not in debt for $200,000 if you're a doctor, right? I mean, it's as expensive to, you have your living expenses and books, same as if you studied philosophy or something else. So overall a very different system.
Who else has a question or a comment to jump in? Anyone? I was just thinking, okay, Martha? Unmute yourself, Martha.
Working on it.
There you
Yeah,
go.
I just want to say a quick thing here. I thought the presentations were all terrific, and I really appreciate this forum. When you start looking at the weaknesses in other systems, I've lived in Canada, I know their system, and the stuff that Tina is describing, I just want to say, just the short version of my comment there is, yes, everything you say is true. And we wish we had those problems. We wish we had a universal system where everybody residing in the United States had unfettered access to care, even if it was unequal in that some better healed people got care a little quicker when it wasn't an emergency, right? Because I know, and Tina, I'm sure you'll back me on this, that anybody who needs care urgently or emergently is getting it, whichever piece of the system they happen to be part of. So mostly when you're talking about jumping the queue, you're talking about non-urgent kind of care. And that's true in the UK, in the NHS, and that's true in Canada, and I can't speak for Denmark personally. Certainly it's not an issue at all, Mary Louise. You would agree. In Cuba, that doesn't even come up. The Cubans learned from the European systems and deliberately designed their single payer system to make it so that you couldn't have that parallel private pay system, because they didn't want that kind of two-tiered system. And they're extraordinarily proud of the equity in their system. So I'll shut up now. Thanks.
I have a question from David. Many years ago, we personally benefited from the NHS in London. It was fabulous. How have the years of Tory and New Labour rule degraded the system? Or is it as good as ever? That would obviously be directed to our UK speakers.
Yeah, I think the biggest problem with the NHS is lack of funding, and I think that's just been really accelerated under the Tory government. As I said, it's been a while since I lived there and actually benefited from it myself, so I can't speak to directly how that feels as a patient. But the NHS, I would say, as a system is one that if it's properly funded, it works great, but there's a huge issue with lack of funding, which was just made even worse under Brexit. There were promises that there would be a lot more money put into the NHS, and that just didn't happen. So there's a lot of pride with British people to hold on to the NHS and to hold on to a system that, you know, people think works for them, and people want that public health, the health system, but it's just the lack of funding is just making it not as good as it once was.
Yeah, the one thing I would add to that, I agree with everything Sarah said. The one thing I would add to that is lack of funding is then used as a pretext to kind of set up, well, lack of funding generates poor results, and that is used as a pretext to then privatize the system. So there is an effort with the Tory government to head in that direction. A country like Britain, which is desperate for any trade deal, particularly one from the United States, will then be more receptive to ideas where, you know, big bad American corporations can then come in and cut up the NHS. I'm not saying that's going to happen, but to Zara's point, you know, if you don't invest in it, it's like anything, right? If you don't invest in your own professional development, or you're in relationships with others, if you don't invest in the NHS, it is going to show signs of not living up to its promise.
Anyone else have a comment or question? Okay, Tina again.
Yeah, so I want to second that you just said. You disinvest, so services decrease, and then you create an incentive for agreeing to privatization, saying, you know, and this is sort of what is also the discussion in Denmark, like in terms of we have a national transportation train network and stuff. So you cut the services, people complain, the trains are not running right. And then there's an incentive to say, well, how about if we sell it? You know, it's all going to be more efficient. So I totally, it's the same thing going on in Denmark as well. So I think that the last 40 years has been this development towards everything private is better. In certain parts of the world, you know, Denmark included. And I think it's turning now, hopefully. And I think we sold off, and that was a social democratic government that sold off the nationalized energy company to Goldman Sachs. And it wasn't even the right-wing government, it was the social democratic government that effing sold off our oil and gas that's nationalized. Anyway, so I think it's slowly turning and coming in a different direction. I think that, you know, if you go back historically in Denmark, there was an, you know, understanding that even if you're doing really well, if you have to step over dead and dying people on your way to, you know, where you're going, it doesn't work for it doesn't work for the whole. And I think I'm hoping that kind of, you know, way of thinking is coming back a little bit.
Rana, you had something to add?
Yeah, I just want to say that whoever brought up the question of the cost, I think it was you, Tina, of medical school. It just reminded me of, I think, something that is really, I think, important when we think about here and how we might want to link those things if possible, because I know in Canada, medical school is more expensive than undergrad, but it's still heavily subsidized. You know, it might cost like, I don't know, 10, 15,000, which here is less than, you know, 1 year of school. So I think if we kind of try to emphasize the need to subsidize that here for students, link up with the New York Health Act to kind of bridge the two so that we kind of take care of different problems. I think that would be really, really helpful.
You should know that a number of medical schools here now in this country have started to offer free medical care, not to everyone, but
Really?
yeah, free medical care. And Columbia Presbyterian has a certain number of not Presbyterian, but Columbia Medical School, Columbia University Medical School does, NYU does. I just want to mention a case out in California. Kaiser Permanente in California also has a free medical school, and they just fired one of their African-American physicians Dr. Corey, because she actually dared to talk about racism in medicine. They claim they didn't fire her for that, but you know, they apparently did. But yeah, there's also a national health service here. So if you go to medical school and then serve 2 years in an underserved community, the government will pay for your health care. So if you go to an indigenous community after you graduate, or an underserved community in an inner city, then the government will pay for your for your medical education. So, you know, we have pieces of it. And the other thing I just want to point out about Cuba is that Cuba is struggling. I mean, yes, they're providing healthcare free to everyone. Unfortunately, the Alam school that I mentioned is now having to charge students from other countries. They can no longer provide it free education for everyone. It's still free for Cuban citizens, although they're not at the Alam school. But for foreign students now, accepting our students, other students are in fact paying. And there are shortages of medications. And some of the conditions in some of the hospitals really are abysmal. The facilities, the plants, the hospital plants are very, very old. And paint is peeling. And, you know, the beds are 100 years old, and there are no sheets. And it's very difficult. And still they are keeping up with the healthcare outcomes, matching the Western nations. So they're doing an incredible job, and under really a lot of strain, a lot of difficulty. And doctors have left because they're not paid very much. And so anyway, I'll end there. So I just wanted to say it's not a bed of roses in Cuba, but they're really incredibly valiant, in my opinion, in persisting to provide universal health care and free universal health care, you know.
We're getting close to the end, but we have a couple more minutes if anyone has some final comment or question they'd like to put. I'd like to just inject one item, because I was struck by the idea of I forget what the phrase was, interprovincial coordination in the Canadian case. And you know, in the US, we've spent an enormous amount of resources and with government subsidies to encourage the use of electronic medical records. And the part of the argument for doing that and for making that investment was to enable people to, you know, to be able to go from one place to another and have access to their medical records. And HIPAA even stands for, if I'm not mistaken, health interoperability, something or other, I forget, or health information. But the idea behind HIPAA was, if you protected people's privacy, then these records could be moved from place to place through the electronic system. What has happened, and I've come across this in the digest that I compile, is that system works very well for billing.
That's right.
It doesn't work well for people to get access to their medical information, and it does not facilitate that for the purposes of providing healthcare. So it's been completely distorted and perverted in that way.
But Tim, it was developed initially as a billing system.
Well, that's probably the reason it works so well in that regard.
Epic was initially a billing system, and then they tacked on the clinical piece.
Okay. All right, Tina.
I'm sorry, I have to just say, because several regions in Denmark just purchased Epic, right, for their blah, blah, blah. And it's creating a lot of problems because it's a system created when there's billing, and there's no billing in Denmark, right? There's no, I mean, it's so anyway. And I also just wanted to mention, when you go, a friend of mine, she just retired, but was a private practicing doctor in Copenhagen, and working in her office in a very, very dense populated area with loads of patients. It's her and her nurse. You don't come into like 10 billing people and da da da. Sometimes they have a secretary, but that's it. So we're looking at a whole different, look at how many people are employed dealing with the money side versus dealing with the medical side. And literally it's astounding. Anyway.
Okay, I think we should probably wrap up. It's 9:25. We've always tried to stay within our 90-minute window. So Julie, would you like to do the honors?
Yeah, and part of the honors, of course, is to thank everybody for being here and our speakers for sharing what it is like. And we need to also think about our ongoing work to have it be something like that in this country and in the state of New York. So there will be some announcements coming up about, somebody's asked me a question in the chat, but I'll have to look at it a different time.
Well,
Maybe that ask a question, but anyway, so there's going to be a couple of lobby days for the New York Health Act. We don't have what the dates are yet. They will be virtual lobby days because this is 2021. And there's also a lot of the usual kind of base building work. So just get in touch with us about that. Some phone banking and text banking. Right now, the New York State Legislature is in its budget season, but the New York Health Act is not within that budget because it will have its own revenue stream. So we can still have that introduced later in the legislative session. So there's going to be a lot of work now that we have this supermajority that we hope behaves in a supermajority fashion with our pressure. So stay in touch about that. Our regular meetings are going to be the first Tuesday as they always had been, and we're a little off track for a while there. Big thanks to
Julie from PNH, a pitch in the chat to ask people to please join in with the PNHP metro area activities. I believe they're also on Tuesday, like every other week, or isn't that correct? I mean, every other month.
That was also off track, but we send to this single payer list all of the PNHP activities as well. So I think, was that you, Martha? I couldn't read and talk. I'm not quite there yet with my brain. Anybody who wants any of that information and you're not on our list and you want to be on it, just put your name in the chat and your email address and you are on our list.
Okay, great.
So thank you again. Rana, with a positive note. Can we hear your positive note out loud?
Oh, I just wanted to highlight that I think we are winning the propaganda war, given that a lot of Republicans, according to some polls, maybe even 60%, something like that, showed support for Medicare for all. So we're getting somewhere.
Yes, I believe we are. I mean, I hate to say that COVID is part of what has gotten us there, but I think that it has really made this whole thing much more naked than it was before. And we have a lot of work to do to make a humane system out of what we have here. So thank you again. Thank you for the models of what more humane care can look like. And we'll keep up the organizing together. Wishing everybody a good night and a safe time. Thank you all.
Thank you. Good night.
Good night.